have the rifle classification where you need the GFR, where you need the serum creatinine, you need the baseline creatinine in the first place, and you don't know where to place your dialysis patient inside. Are you going to practice the rifle criteria, or are you going to practice the Akin criteria? In Akin criteria, it's very easy, okay? But the point is, any slow increase in serum creatinine, your Akin is going to miss out. And stage 3 has a lot of mess in it, right? So, which classification are you going to use in your practice? Are you going to use rifle? Are you going to use Akin, or something new? Or are you going to take something new? Okay. So, there is heterogeneity in the utilization of the criteria defining and classifying AKI, such as the use or non-use of urine output as a criteria, to whether to take the baseline creatinine or not, to estimate the GFR instead of variations in serum creatinine for 48 hours. All these things is a mess up, right? This is the basic difference between the rifle and Akin, right? So, considering all this mess up, we came with a new criteria. That is the Kidney Disease Improving Global Outcomes Work Group, that's KIDGO, recently combined the rifle and Akin's classification to establish one classification of AKI for practice, research and public health. Okay. So, now it's KIDGO. So, in your exam, they are going to start with rifle and they are going to ask you what are the limitations of rifle. They are going to ask you what is Akin, what are the limitations of Akin, and why did they want Akin in the first place? Why did they do modifications, and what are the modifications from rifle to Akin? Okay. What are the limitations of Akin? Why they are not using Akin? And what is the new form of the classification? What is KIDGO? Okay. These are the questions they are going to put forward. Okay. Very, very easy reference. If you answer this, you are going to get full marks. So, now this is the KIDGO classification. Stage 1, Stage 2, Stage 3. Okay. We have serum creatinine values and urine output values. Stage 1, 1.5 to 1.9 times the baseline in 7 days, or increase of 0.3 milligram per deciliter in 48 hours. Urine output criteria less than 0.5 ml per kg per hour for 6 to 12 hours. Stage 2, increase in serum creatinine of twice or 2.9 times from baseline. Urine output criteria less than 0.5 ml per kg per hour for more than 12 hours. Stage 3, serum creatinine increase of 3.0 times baseline, or creatinine if it's more than 4, or initiation of RRT in patient less than 18 years, or eGFR less than 35 ml per minute per 1.73 meter square, and urine output criteria less than 0.3 ml per kg per hour for more than 24 hours, or anuria for more than 12 hours. Okay. So, conclusion, the integration of new biomarkers of AKI into the clinical classification could increase the sensitivity and specificity of AKI diagnosis, overwhelming and taking off some of the limitations of your traditional markers like creatinine and urine output. So, you need to practice KIDGO classification, and if you have biomarkers, you can combine the biomarkers along with your classification. This can aid particularly in prognostication of your AKI patients. Okay. Thank you so much.